Um, First of all, I thank Kavita for organizing this e-class, and I'm coming back after a long time. I think 10 months back I gave a last presentation, and then I'm coming back again in the new topic, Hypertrophic Cardiomyopathy, Etiology and Management. So, I know that it is a bit rare disorder, but still it is essential to understand so many newer aspects about the hypertrophic cardiomyopathy. So it is actually a genotypic disease which we are seeing phenotypic expression in the form of asymptomatic to symptomatic. Now you can see Miklos Ferrar, 24, Hungarian football soccer player. So he was playing in European League and he was shown yellow card. Soon after yellow card, he got terribly disappointed and suddenly fell down, and that was his last breath and he died. Similarly, you can see the famous basketball player in USA. While he was playing and he was learning to put a ball, and he fell down and died. So you all know Elvis. Lot of controversy about his death, about drugs, so many problems. But the last Daily Mail from UK report showed that his tissues were coded genetically, and then found that he died due to cardiac disorder with a gene mutation which are found in hypertrophic cardiomyopathy. So many people every day will see, even here, the parents will come, mother will come, that the father died due to sudden cardiac death, and they come. You can see here this boy, 13 years boy, became very, very famous YouTube star. Actually, he started online gaming and he earned millions of rupees at the age of 13 years and died. And autopsy showed that there was hypertrophic obstructive cardiomyopathy. So what we see is the phenotypic expression of a genotypic disease. A hypertrophic cardiomyopathy is the most common form of monogenic heart disease, affecting up to 0.2% of the population. The clinical course of hypertrophic cardiomyopathy is remarkably variable, ranging from lifelong asymptomatic state to mutation carrier status to early sudden cardiac death, what we saw in the previous slide. In the last 2 decades, over 20 genes, mostly encoding sarcomeric proteins, have been identified responsible for the hypertrophic cardiomyopathy from infancy to the late adulthood. The molecular mechanisms of hypertrophic cardiomyopathy are unclear. Potential pathways to some extent described, which includes altered calcium cycling and sarcomeric calcium sensitivity, which leads to increased fibrosis and disturbed biochemical stress sensing and further impaired cardiac energy homeostasis. An improved understanding of pathological mechanism happened, and so we have actually a lot of changes in terms of management and treatment. So you all know that cardiomyopathies are structural, functional and myocardial diseases. The absence of systemic hypertension, coronary atherosclerosis, valvulopathy or congenital heart disease sufficient to explain the cardiomyopathy. Whereas in case of hypertrophic cardiomyopathy, there will be an increased ventricular muscle thickness or mass in the absence of obstruction or loading conditions, which is sufficient to cause the abnormality. This was the last definition by Elliott in 2008 and published by American Heart Association. So if you look at the published data from the American Heart Association cardiomyopathies in children, essentially there are two major differences. One is familial, second is non-familial. I'll just take 1 second actually. I'm sorry. American Heart Association cardiomyopathy in children, there are essential familial and non-familial. So you have hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia, restrictive cardiomyopathy, and unclassified. So again, these familial are divided into undefined and disease subtype is there. Similarly, non-familial or non-genetic, which are idiopathic, and again there is disease subtype are described. So if you look at the hypertrophic cardiomyopathy, genetic in nature itself, it is predominantly familial one is going to involve the sarcomeric protein. So it may be associated with malformation syndromes, associated with inborn errors of metabolism, associated with neuromuscular disorders. Whereas a non-familial one associated with obesity, inborn errors like infant born to the diabetic mother, or some of the unknown entities, undescribed entities, are not identified like athletes or amyloidosis. All those are classified into hypertrophic cardiomyopathy. So it is crucial to understand the sarcomeric form and what are the mechanisms, at what level of protein is going to cause the dangerous form of the hypertrophic cardiomyopathy. So sarcomeric form is the commonest one, which is autosomal dominant. You can have carriers, and there will be a missense mutation of the genes. A mutation involves the change of a DNA base for another, resulting in the replacement of an amino acid in polypeptide for another. There are at least 20 genes are identified in HCM, but of which 3 are going to be very important. Whatever gene which is causing this kind of problem, we are actually seeing the phenotypic expression in the form of hypertrophy of the cardiac muscle. So a genotypic disease which is quite maybe asymptomatic and won't express any external features, but it has got a phenotypic expression of severe cardiomyopathy in the form of obstruction. So if you look at the sarcomere here from the cardiac muscle, which is causing there's a myofibril which has got so many sarcomeres with actin and myosin filaments. So you have in sarcomere a thick filament and a thin filament. I'll just move my camera box other side. Yeah. So that you can see them. So you have thick filament and thin filament. The thick filament is the beta myosin heavy chain. We can see that, and this myochain has got regulatory and essential light chains are there, and there is a cardiac myosin binding protein C here. Whereas the thin filament, you have got actin, tropomyosin, troponin I, troponin T. So anywhere in this protein, due to genetic abnormality or missense of the amino acids, may cause a serious problem in the form of either hypertrophy or extra myofibrils or leading to the hypertrophic cardiomyopathy. Okay. So Sorry for that. My students, they just joined. They did not get the connection. So if you look at the sarcomere here, again, you all know that the thick filament and thin filament, there is a sliding motion leading to in the cardiac contraction of the thick filament essentially has got cardiac beta heavy myochain here. You can see that, and mutations can take place on this either head here. You can see where the binding sites, or you can have mutations on the actin, that is the thin filament, leading to problems in the troponin C, I, and excitation contraction coupling, where the calcium reflux will be lost, leading to ultimately some kind of problems in the form of a phenotypic expression of hypertrophic cardiomyopathy. Eventually, it is going to cause a cellular necrosis or apoptosis, which we are going to show in the next few slides. So, here you can see that essentially there are two mutations, that is MYH7 and MYBPC3. These are the missense which replaces the amino acids in the myosin 7 site, leading to the hypertrophic cardiomyopathy. So, at this point of time, there are three important mutations which are found and leading to the hypertrophic cardiomyopathy. So here we are showing only two, whereas the other mutations in non-sarcomeric proteins such as vinculin also result in hypertrophic cardiomyopathy. You may see other problems like in case of Noonan syndrome, Leopard syndrome, and Fabry's disease. All these are going to have a similar kind of phenotypic expression of hypertrophic cardiomyopathy. So if you look at it here, you can see here various levels of the proteins which are involved, leading to this is actually published data from the Nature journal, and you can see the myosin heavy chain problems here, and you can see the problems at the myosin filament, which is at the binding site, troponin C and I, where you can have mutations here, and or myosin binding protein C abnormality, or troponin Ti, leading to the hypertrophy here. This is the normal heart where you can see the hypertrophic cardiomyopathy here, and the histology you can see here, pathological specimens shows here fibrils which are arranged here in a normal fashion, where here hypertrophy, and in between you can see there is a significant fibrosis in case of hypertrophic cardiomyopathy, eventually leading to cellular apoptosis, and there will be dilatation of the ventricles, and then heart failure is possible. So there are various models people try to hypothesis, do some kind of work, and then genetic studies showed that important aspects. You can see here how the myocytes in case of normal, which is going to have problems during either at HCM mutations. Here you can see here at the sarcomere thick and filament level, or abnormal calcium cycling, leading to the problems during the calcium influx and excitation contraction coupling. In these conditions, leading to the cellular death here, non-myocyte proliferation and matrix expansion, leading to the fibrosis here. Ultimately, it will be replaced by the significant fibrosis in the presence of hypertrophy. So, increased myocyte death and increased focal and interstitial fibrosis, leading to the dilatation of the cardiac chambers after particular time of the hypertrophy. So, there are various pathways and disease mechanisms described, but importantly, you can see that there are 4 important pathways which are important. One is the disturbed biomechanical stress. Here, biomechanical stress means the thick and thin filaments will slide during a cardiac contraction in the presence of these abnormal mutations, abnormal protein. The thick and thin filaments or sarcomere problems will be significant enough not to produce such a kind of contraction. There will be hypertrophy at the same time and leading to severe shear stress at the myofibrillar level. That is one of the major important mechanisms. Second one is there is impaired calcium cycling and sensitivity. Even though there is a good significant amount of calcium at the cellular level, which may not be useful, and there will be some significant disturbance at this level and non-availability of calcium, again which causes a significant problem at this point of time. And the ATPs which are available from the mitochondria, there will be significant alteration of the myocardial energy which is from the myocardia may not be sufficient even in the presence of a hypertrophy, again which is an indirect evidence that it may trigger the cellular apoptosis at the end, leading to the fibrosis here. You can see that various genes which are acting and leading to the significant fibrosis at that point of time. So these four important biomechanical stress and impaired calcium cycling and altered energy homeostasis and increased fibrosis are going to be important cellular molecular mechanisms which we all should know. So the mutant contractile protein in the sarcomere, that is essentially either beta myosin heavy chain or actin, but for an example, if you take beta myosin heavy chain, there will be decreased contractility leading to both diastolic dysfunction in the beginning. Later on, there will be systolic dysfunction. Even though there is a significant amount of muscle mass, the stroke volume is going to be reduced, the wall stress is going to be increased, there will be activation of the mechanoreceptors in the left ventricular myocardium leading to the compensatory hypertrophy. That hypertrophy is not going to be useful because it may be associated with the bizarre nature of the sarcomere arrangement and then fibrosis eventually. So multiple mechanisms play a major role to decrease the cardiac contractility. Initially it will be diastolic dysfunction and subsequently it is going to be systolic dysfunction. But mutation contractile proteins incorporated into sarcomere, that is what the sarcomere 3 genes mechanisms which are causing abnormality. What I told you just now a couple of slides back, inefficient ATP usage, even though there is a mitochondrial ATP is there, it may not be used properly and there will be increased cost of force of contraction also, and the amount of ATP which is present, which may not be available for the normal sarcomere, and it will be depleted very rapidly. And there will be other mechanisms that play a major role. There will be increase of AMPK, cytosolic calcium, and calcium dependent signaling. All this leads to again hypertrophy. Whereas the reduced ATP and increased mitochondrial demands, which increases the reactive oxygen species, leading to the failure at the cellular mitochondrial level, leading to the apoptosis. This is going to be eventual pathway in case of hypertrophic cardiomyopathy. So the 3 important genes which we all should know is beta myosin heavy chain, that is MYH, and B, and myosin binding protein C, that is NYBPC3, and troponin T, that is also going to be very important. In close to 20% of the patients may have this kind of abnormal mutations due to relocation of the amino acids. So these are all various important genes and proteins which are involved. Very difficult to remember all these things, but at least what I told you, 3 genes, and important thing is myosin heavy chain and cardiac troponin T, C, and I, these are the important things what I told you, and these are all somewhat relatively less genes which are involved, close to all put together less than 10%, which leads to the hypertrophic cardiomyopathy. So if you look at closely the genes and chromosome location, this is going to be again an important, what I told you in the sarcomere, the actin and myosin filaments here, thick and thin filaments. In the thick filament myosin, you can have a 14q missense deletion or 12q translocations or 17q, which is the people are studying on that, and the established one is 3p again. These are the important ones which are actually involved. If you look at that, cardiac beta myosin heavy chain is in the 14, cardiac troponin is 1q32 level. These are all sequencing done and then found that abnormal genes are responsible for the hypertrophic cardiomyopathy. So these are the one which correlates and then see the various levels of chromosomes and genes which are actually defect leading to the abnormal proteins and eventually leading to hypertrophic cardiomyopathy. So this is again an important thing. What gene is leading to what type of phenotypic expression? So we are only looking at this moment phenotypic expression, but we started last year with the help of MedGenome, Dr. Priya Choklinga and my colleague Dr. Cellular. We studied some families of hypertrophic cardiomyopathy, and we found some of the genetic abnormalities which I am going to show you. So if you have a beta cardiac myosin heavy chain, there will be predominance of high penetrance and severe hypertrophy. This is the most dangerous variety of hypertrophic cardiomyopathy, and they have unpredictable variable risk of sudden cardiac death according to the mutation. Whereas the cardiac T troponin, which is low penetrance and mild hypertrophy associated to early sudden death. Whereas alpha tropomyosin, there is a large phenotypic variation, predominance of mild hypertrophy and variable prognosis, and which we may detect during a late adolescent or during adults. Some kind of hypertrophy will be actually evaluating, and we may not find any cause. Whereas the myosin binding protein C, it is an incomplete form and late penetrance form, which we don't see in children and adolescents. You see usually in the fourth to sixth decade, and it is usually supposed to be the benign one. Whereas essential and regulatory myosin light chain, again it's a high penetrance and mild ventricular obstruction will be there, but it has got a bad prognosis. They may go into cardiac failure in the later part of the life. So what you understood here is any myosin heavy chain form which is involved is going to have the poor prognosis. So whereas the cardiac I troponin has got typical atypical forms of cardiomyopathy, and the alpha cardiac actin again is a high penetrance, but which may present in the very early and which may progress to very late. So these are the important phenotypic expressions correlating with the genetic problems which we all should understand and try to evaluate that in terms of prognosis when you are talking to the family, or futuristic targeted gene therapy may be possible when you are counseling the family for the subsequent children. So what is mean by phenocopies? A person who has an environmental condition that mimics a condition that is produced by a gene. That means you have a hypertrophic cardiomyopathy, similar pictures you see, but none of the genes are responsible for this condition. Probably we can call it as a phenocopies. That we see a lot of cases in children due to Fabry's disease, Leopard syndrome, Noonan syndrome, and other lot of syndromes which probably I don't know. We have to go on exploring those kind of possibilities, and I have a list of those conditions which I am going to show you. So these are all called as non-sarcomeric hypertrophic cardiomyopathy. Same pathological phenotypic expression you will see, but genetically they are totally different and variable prognosis will be there. So these are all hereditary errors of the inborn errors of the metabolism, which is involved in the various enzymes, which you can see oxidase phosphorylation, combined respiratory chain deficiency, and fatty acid metabolism, and mitochondrial. All these syndromes, they mimic like a hypertrophic cardiomyopathy. That is the reason when you are dealing with the hypertrophic cardiomyopathy, it is mandatory to do the metabolic workup prior to have the total exome sequencing. So these are the genes, some of the genes which are not related to the sarcomere and responsible to some extent of hypertrophic cardiomyopathy, and the prognosis is highly variable depending on the condition to condition. If you look at here on this disease, we ourselves in our institute, we have got one of the highest volume of Pompe's disease, close to 15-16 cases, where alpha-1,4 glucosidase deficiency, those conditions are having a very malignant course, and sudden cardiac death and heart failure is quite common. Whereas in case of Noonan syndrome with a cardiomyopathy, hypertrophic cardiomyopathy, they are asymptomatic for long time. I have patients of even now 25 years old child. Last month got admitted with some kind of a heart failure. We managed him, and it is variable. So what I mean to say, you can have malignant course, benign course, and various genes are involved, and they will have other phenotypic manifestations in the form of other systems involvement apart from the hypertrophic cardiomyopathy. What are the peculiarities compared to the adults? Variable phenotypic expression, not necessarily they should mimic the adult cardiomyopathy. Right ventricle also may be involved, whereas in case of adults, involvement of the right ventricle is somewhat relatively rare. And during my post-graduation, I remember vaguely that one case we saw with the right ventricular involvement in case of hypertrophic cardiomyopathy, but by and large, you don't see right ventricular involvement. Whereas in case of, I had child actually, a girl child, and appearing like a Noonan syndrome. Later on, we found it, she, actually earlier we used to think the girls, they don't develop Noonan syndrome, but Noonan syndrome is seen even in the girls, females, and in that particular case, there is a right ventricular cardiomyopathy with some obstruction. We operated. Still, she continues to have the right ventricular hypertrophic cardiomyopathy apart from left ventricular cardiomyopathy. Apical involvement is very rare in children, and the symptoms are dependent on the physical activity and the stress, because infancy, early childhood, toddler group, late childhood, adolescent, their physical activity, catecholamine levels and stress are highly variable. That's why it's very difficult to predict who is the child going to have the sudden cardiac death in case of the children. And these children are relatively asymptomatic compared to the adults. That's why we don't know who is going to develop a sudden cardiac death. I have so many illustrative case examples of sudden cardiac death in children. Last year we have to write an article in the local paper. There was a state level competition, and one child suddenly died on the ground in one of the athletes participating in the sports, and found to be autopsy showed that there was a hypertrophic cardiomyopathy. You must have heard a lot of police during a drill, they suddenly collapsed and then found sudden cardiac death. These are the patients who probably we need to do autopsy and find the cause. Some of the patients may be having hypertrophic cardiomyopathy. So looking at non-sarcomeric variants, those are common in children apart from sarcomeric variant. Classical example is asymmetric septal hypertrophy you see in infant of diabetic mother. We very commonly we see even in fetal echo that untreated case of gestational diabetes, you will see a significant asymmetry of the septal hypertrophy. You can see that, and sometimes they may have a left ventricular outflow tract obstruction, and they present with PPHN like a physiology. So hypertrophic cardiomyopathy in case of infant of diabetic mellitus, they don't present like any of the hypertrophy, they will have PPHN like a physiology at birth, and they need more amount of preload, and they need beta blockers instead of inotropic agents like a dobutamine and diuretic. So that is what the common errors being done without doing proper echo in case of infants of diabetic mother. If you start giving dobutamine and giving Lasix, is going to be more dangerous and disaster, and they don't make it. So whereas case of POMPs, which we sometimes see with gross hypertrophy, recent times we have seen close to 4 cases with gross hypertrophy here, and shortened PR interval, and floppy infant, drooling of saliva, and low husky voice. These are some of the clinical signs where you pick up that it is a hypertrophic cardiomyopathy of POMPs variant. So you do the tissue Doppler velocities, all velocities will be less, and also the myocardial contractility compared to the a non-POMPs hypertrophic cardiomyopathy, it will be always relatively less. So these are most malignant forms, and I don't think we have a grown-up child of POMPs disease who is receiving NJ at this moment. I think we have got only one child follow-up. I think it's still toddler, and hypertrophy disappeared in, with the NJ after I think 6 to 8 months. My colleague Dr. Shweta is working on that POMPs disease. She has got a collection of close to 15 cases. So this is one of the cases recently presented with the heart failure, and we found that the NGM levels are pretty low. Even sometimes you see close to 0 levels. Recent 2 cases we found that there was no NGM alpha glucose. The NGM was virtually 0. So other syndromes. This is a boy from Orissa. You can see that multiple nivae lentiginosis here, and looking like he is the Noonan syndrome called as Leopard syndrome. And my fellow Dr. Sachi actually worked on this child and did a skin biopsy which confirmed the same, and we found that a significant hypertrophic cardiomyopathy, obstructive cardiomyopathy in this particular child. You can see that the left ventricular outflow tract is severely obstructive here, mid-cavity obstruction. There is some degree of mitral regurgitation as well as regurgitation you can see here. So his resting gradients were more than 80 millimeters of mercury, and there were symptoms, and he did not actually benefit from the medications which we use generally here, beta blockers, and a combination of therapy called disopyramide. He did not improve and continues to have symptoms. Then we have to eventually operate on him, and then he is relatively symptom-free, still on medication. I'll show you those pictures. So these are HOCM. You can see that here mid-ventricular obstruction followed by surgery. That a relief of the obstruction is here, and gradients significantly reduced followed by the surgery. It was pretty high earlier. It was more than 150 or so. Whereas the Noonan syndrome and the variant of Leopard syndrome is germline deficiency, germline transmitted, and somatically acquired. 2 types involved at different amino acids. Here we can see that again here missense amino acids leading to the Noonan syndrome. Not necessarily all Noonan syndromes they develop a hypertrophic cardiomyopathy. A variant of Noonan syndrome only they develop hypertrophic cardiomyopathy. Otherwise, you all know by and large they develop a pulmonary stenosis, sometimes a peripheral pulmonary artery stenosis. So the most important articles which are published, and also from the American Heart Association from Professor Moran, and he classified into 4 major variants. That is again a phenotypic expression of a genetic disease which we are talking. A type 1 hypertrophy is about 10%, and you will have predominant posterior left ventricular wall involvement and anterior mitral leaflet involvement leading to the left ventricular outflow tract obstruction. So this acts like a little bit of asymmetrical septal hypertrophy, but here anterior posterior one, sorry for that, posterior left ventricular wall is thickened, and these patients will have mitral regurgitation and significant amount of left ventricular hypertrophy. Whereas type 2, that is the second common one, hypertrophy involves the anterior and posterior septum. You can see that here. This is again asymmetry, but it is not the septum which is going to be involved. It is the ventricular septum here significantly, but not uniformly will be involved, and there will be some kind of asymmetry seen in this case. Whereas the type 3 is the commonest one, which we see 52% of the patients, which involves the anterior and posterior septum as well as the lateral T wall here, and you see some kind of asymmetry, but overall gross hypertrophy is seen in case of adults of this kind of variety. Whereas type 4 is somewhat seen and involves left ventricular regions other than the anterior septum and posterior septum. Apical area is also involved in this particular type of thing. So you have a normal myocardium here. You can see the what I have shown you, the Leopard syndrome or Noonan syndrome, where the septal protrusion, septal hypertrophy leading to the obstruction here, and here you can see a significant hypertrophy. They can have midventricular obstruction, they can have mitral regurgitation here, whereas conditions like this, where you can see the ventricular septum is not involved completely and they can have hypertrophy, they may propose sudden cardiac death due to arrhythmias, but left ventricular outflow tract obstruction is not significant. Whereas here you can see these are the dangerous cases where eventually they will have diastolic dysfunction and they develop exercise-induced kind of problems and pulmonary edema, pulmonary congestion, and eventually they may develop kind of cardiac failure. So the management part, I am not going to tell you how we are going to do echocardiogram, evaluate all those things is not possible, and also the topic is very specific about this genetic aspect as well as the management. So the management includes primary and secondary prevention of the sudden cardiac death. That is very, very important because most of the times these patients are asymptomatic. And relief of left ventricular outflow tract obstruction by surgical or ablation in failed cases due to medication, Pharmacological treatment play a major role as a first line of treatment, and subsequently we go for the surgical. Whereas in the future, targeted therapy based on the molecular pathways are going to happen, and we are all going to witness that in the next 1-2 decades time. So how you are going to prevent the sudden cardiac death? That is going to be important, and we all should understand the various risk factors. So first and foremost thing, whether any non-sustained ventricular tachycardia present either at rest or exercise, whether it is documented or 24 hours of altered death. And what is the amount of fibrosis or scar by MRI, which is very important. And the severity of the left ventricular hypertrophy, you can calculate LV mass by the echocardiogram or LV mass by the MRI. And abnormal exercise, abnormal blood pressure response during the TMT, that is also very important. If the BP goes up very high or drops down, that is due to obstruction, which is going to be very important to prognosticate. And outflow tract obstruction during exercise or during any kind of activity, if any patient in the family or sudden cardiac death or unexplained syncope is going to be an important risk factor to tell that this patient is going to develop sudden cardiac death. And again, eventually, family history of sudden death is going to be very crucial, which we all understand that. So this is again a paper by Professor Maran from the circulation, how you are going to assess and identify the risk factors of the 474 children, adolescents, and young adults. So you can see that, and how many survived, how many had got actually sudden cardiac death here due to various problems, sudden death, ventricular hypertrophy, obstruction, arrhythmias, all those things. So I request you to go through this paper, very important paper, and educate yourself. So important aspects are risk factors, previous cardiac arrest, spontaneous occurring sustained ventricular tachycardia, family history of sudden cardiac death, identification high risk mutant gene by complete exon sequencing, abnormal blood pressure response to exercise, non-sustained ventricular tachycardia and 24 hours Holter, and some people say that interventricular septal thickness more than 30 millimeters. That it is not proven, because even though there is a thickness, there is a variability of the prognosis. So, however, you should remember all those things. These are essentially came from the European Society of Hypertrophy. Last abstract was in 2008. So, how to restrict the activity? It is really serious concern and question, especially in children. You don't have any clue how to restrict the activity. But however, you can go through the scientific statement and recommendations for the physical activity and recreation, sports participation in young patients and children with the HCM, which was published last in 2004. After that, they did not update it. Try to avoid restriction of isometric exercise. So any body weightlifting, heavy weightlifting is not recommended. And level 3 exercise. Level 3 exercise is soccer, football, American football, basketball, tennis, and competitive sports at the school are not allowed and not recommended in this particular group of patients. So, what we saw in the beginning of the slide, this is going to happen. They will have sudden cardiac death, either playing the rugby heavy game or football. So, when you want to start medications, you need to have definitive indications. You can't just like that to start medications in an asymptomatic, non-obstructive non-left ventricular outflow tract obstruction. But in adults, people used to start calcium channel blockers with very cautious, careful in case of asymptomatic patients in a subgroup of patients. But whereas in case of children, in case of reduced functional capacity, exercise intolerance, a regular participation in all games at the school, and ECG showing ischemia and blood pressure response during exercise test is going to give an important information to start the medications. People started various medications. Beta blockers are the wonderful medications and first line medications to reduce the exercise-induced left ventricular outflow tract obstruction. We in our center, we used to start beta blocker and disopyramide earlier as a first line treatment. Now disopyramide availability is becoming very difficult. That's why now we are confined to the beta blockers. We optimize the dose of beta blockers. Rare cases we are getting disopyramide. Verapamil is not. I am not aware that we used in children, but I have seen in adults they are used in reserved cases where selective cases with less symptoms, or if there is no LVGOTO, only isolated cardiomyopathy without obstruction, probably patient may be benefited to some extent. Amiodarone reduces the risk of sudden cardiac death. In fact, this is the only medication which is proven in the drug trial that which reduces the sudden cardiac death, and high risk patients may be useful there. Diuretics, to my understanding, it's contraindicated. I never give diuretics unless patients are admitted with only one patient admitted with hypertrophic cardiomyopathy, eventually progressed to the dilated form and dysfunctional form, where we have to give intravenous diuretics. By and large, it is not indicated and reserved only for patients with pulmonary edema and end-stage disorder. Beta blockers, very important, and propanol 1.5 to 3 milligram per kg per day, and essential to monitor the heart rate in small babies sometimes, and sometimes where there is a drug intolerance, if they have any bronchospasm, we start metoprolol, long-acting metoprolol 6 to 12 milligrams per kg we can give. Verapamil, again I told you that paradoxical effect may be noticed in case of children. That is the reason why we don't use verapamil in this. So if we have persistent gradients even with the beta blockers, symptomatic state persistent and there are no symptomatic relief, probably disopyramide Norpace, you can get it Norpace, and symptomatic relief can be obtained. And I remember that 2-3 patients, they behaved very well with the combination of beta blockers and disopyramide. But standalone disopyramide is not recommended, and we don't give. We always give with the combination of beta blocker. AV conduction is important. They may develop acceleratory AV conduction, hence combined with the beta blocker, and dose is going to be 10 to 30 milligrams per kg. Surgical myectomy in case of refractory to medical management and section of anomalous chordae, surgical relief of papillomageal fusion and extended septal myectomy, mitral valve replacement are important aspects of various types of surgical procedures. In our hospital, in the pediatric category, I can only gather 4 cases where we did the surgical myectomy to relieve the obstruction to repair the mitral valve. Otherwise, we don't have that much of experience at this point of view in case of surgical myectomy. So, what a surgeon essentially do, he takes out the scoops of the intraventricular hypertrophic septum below the aortic wall or mid-ventricular level at the level of the obstruction. Prior to that, intraoperative transesophageal echocardiogram is going to be mandatory. So this is one of the case. Apart from that, what I had shown, Leopard syndrome, where you can see the obstruction here, significant obstruction of left ventricular outflow tract obstruction. This is the 4-chamber view. Here you can see the hypertrophic cardiomyopathy, very malignant form, family person, father died due to hypertrophic cardiomyopathy, and we have to remove the muscle here, obstruction, and you can only relieve the obstruction to some extent, but you can't treat the genotypic disease. It is a phenotypic expression of the malignant form of the sarcomere beta heavy myosin problem. So that patient developed ventricular septal defect because of the aggressive septal resection. You can see the septum is removed here to some extent to relieve the obstruction, and we have to subsequently close using the ventricular muscular devices here. So pacemaker and automatic implantable cardiac defibrillator, we don't give dual chamber pacing therapy in children, and they generally don't benefit, and which is proven in the literature that a standalone dual chamber pacemaker is not indicated in these cases. Only patients who are high risk for sudden cardiac death with the family history of SCD or documented a sustained VT or non-sustained VT in a Holter, those are the candidates for the AICD implantation. And in our hospital, only 2 children received AICD in the last 2 years. Earlier, there were many. I don't have data at this point of time. So, appropriate ICD implantation and benefit from the ICD implantation, you can see from the Professor Maran paper here showed that a significant benefit from the ICD implantation from the events of the sudden cardiac death. Percutaneous alcohol ablation, it is essentially to the adults, and we have never done in case of children, and I don't have any experience, and I saw our adult guys doing this kind of procedure in couple of occasions, and the principle is you are going to inject the alcohol, occluding the septal vessels with the balloon here and producing the necrosis of the muscle of the septum here, which is causing the obstruction. That is what the principle, and at this moment I don't think it's an established procedure in case of children with hypertrophic obstructive cardiomyopathy. Whereas whole exome sequencing, this is the one of the family where we did, and my colleague Dr. Cellular involved in this kind of workup, and we found that there is an abnormal mutant in this particular patient and autosomal dominant variety, and we eventually counseled the family, and then child is under on follow-up with the medication, and there is a family father also involved with the same kind of mutation, and whole family's exome sequencing we did, and 3 people are involved in this particular disease. So survival, you can see the survival compared to the normal human beings, normal individuals. This is again data from the USA, same data from the circulation showed that there is somewhat reduction due to sudden cardiac death at the 20 years. Whereas when you look at the data critically, hypertrophic cardiomyopathy events and sudden cardiac death in form of life-threatening events in gene positive cases, you can see the events are quite significantly high. They may be benefited with ICD in this particular scenario. So I would like to summarize at this moment. Phenotypic expression of hypertrophic cardiomyopathy is highly variable from the asymptomatic state to the sudden cardiac death. The understanding of the genetic mutation involving sarcomere may be useful for the understanding of the pathophysiology, what I have shown you in the last few slides. Management is predominantly symptomatic. You are only treating the left ventricular outflow tract obstruction, which is an expression of the malignant genetic disease in most of the cases, and the surgery is essentially reserved for the drug refractory cases to relieve the left ventricular outflow tract obstruction, and by and large we don't send them for surgery as a first procedure, as a first indication. Whole exome sequencing may be useful, which is available. They charge around 40,000 rupees at this point of time. For target, maybe it may be useful for targeted therapy for the important, and the next generation sequencing is very important in this kind of patients. So I thank you very much. If there are any questions, you can probably ask, or I think I took almost close to 1 hour time. If you have time, I can ask, or you can email me. You can take a mail from the coordinator.